So, as we look across the country, clearly there'll be wide variations in how different integrated care systems and areas within each ICS, the extent to which they have people living with HIV, some of whom will be receiving services already. There'll be also a considerable amount of unmet need in many communities. So how should ICSs identify and meet the needs of people with HIV? Ruth, perhaps if I can start with you.
Yes, so I think the bloodborne virus opt-out screening programme, which I referenced earlier, is a really important part of this. So as I said, if you go to A&E and have a routine blood test, you'll also be tested for other bloodborne viruses. And this has been a massive success in many places, many parts of the country already. But I think what we've learnt from that is that the funding at the moment is not necessarily attached to how many people you then identify, but it's more attached to how many people you screen. And I think that, the main thing is that the whole programme is being funded and it's a fantastic thing. But I do think we need to work in a system where, when you have limited resource, the funding does need to follow where we have the highest prevalence. So that, what we found particularly for hepatitis more than for HIV has been that even if you identify a patient, they might not then necessarily stay in the system. And I think it comes back to our point about working with local communities. I think it's really important that the funding also goes into working with local communities and peer support workers to understand why people might not be going back for their appointments. Because it feels like we're only really doing half of the programme if we just focus on identifying them in the first place.
And is that a significant issue, that the number of people who aren't returning and engaging?
I think it's got much better, but I think it's still something that it's really valuable to put resource into, both in terms of putting money into local communities and understanding their need, but really to get more information about what does make a difference. What does make a difference in terms of whether people return to their appointments? Does that vary by ethnicity? Does it vary depending on whether you're on a 0 hours contract? It's that thing about linking it to wider determinants, and that's why I think a population health approach is the right one for HIV, because that takes into account the whole person rather than just a condition they're living with. But yes, I think it's very important that we are able to demonstrate the value of that investment as well. So a figure that I often use, I think, is 280 grand it saves the NHS for every patient that's identified at an early stage as living with HIV. And I've certainly found that very helpful in terms of demonstrating the use of the opt-out programme. So I also think there's something for us to do locally in terms of saying, actually, this is why it's valuable, this is the difference it makes to patient outcomes, and this is the difference it makes to all of us in a system with limited resource.
Cheryl, what's your perspective on how ICSs should be providing services? And is there a concern that there's a perception that sort of HIV is a problem that's been sorted, and people don't think about people living with HIV into old age, the fact that there's still big campaigns going on to reduce and indeed eliminate new infections over the coming years? Very ambitious programme, but doable. Well, what's your perspective of the profile of HIV now in care services?
Yeah, I think that's a very important point, that I think there is some sense that we've solved HIV now. And obviously there are 100,000 people who are living with HIV across the country. So even if transmission ended tomorrow, there's still 100,000 people who need proper treatment and care. They're living in a very stigmatised situation, unfortunately, in society. So across the piece, in terms of their quality of life, we need to be thinking around those different aspects of the care of people who are already living with HIV. And I think the point about high prevalence areas is well taken. But also, I think we need to consider people who actually live in low prevalence areas who sometimes will have a worse experience precisely because the system isn't set up to deal with them. So often in higher prevalence areas, you'll have perhaps GPs who are pretty well versed in HIV, whereas that's much less likely in an area. If you're living in a very rural area, you might be the only person at your GP surgery who has HIV, and you might be the expert in the room when you're going for your medical care, rather than the medical professionals. So I think we just need to think sort of across the piece. The other thing I'd like to say on that is around open access, and I think that's one of the things that we have a slight concern with around the ICSs. The planning and the budgeting is all going to be around local need, and it's a very sort of specific geographical footprint. And I think that makes sense across the piece for all sorts of reasons why that's a good idea. But at the same time, you'll have some hospitals where almost half their patient cohort will be coming from out of the area. So I think we need to just make sure that the engagement with clinicians and with people living with HIV themselves takes into account that fixed geographical footprint, which is probably quite different for HIV than it is for other health conditions, actually considers need sort of across the piece for all the people who might be coming for care in that area. So that's another area that we think probably needs a little bit of consideration in terms of that engagement piece we've already talked about. And then I think the other thing I'd like to say on unmet need is sort of going back to that engagement. We can talk in very general levels about, we know, for example, there's significant need around mental health. We know there are some difficulties with social care provision, things like that. We know that support services are now very underfunded. So actually, what is a vital service actually probably isn't getting the sort of level of funding that's required. But those are sort of very top level national sort of priorities. And actually the specifics of the local system are really going to depend on that engagement, and for the ICS to really have that engagement, which we've already talked about, I think it's really important to consider that those needs might be different in different areas, even though we're talking about the population perhaps with one set of, obviously with HIV, but the comorbidities are probably reasonably common across the piece. But even so, those wider determinants of care really might make those local needs very different, and perhaps how people are embedded in communities, for example, that's going to be different in different areas. So I think that engagement that we've already highlighted as being really important, I think that's actually a key for ICSs to think about when they're talking about responding to unmet need.
Jim, comorbidities has already come up several times. We tend to accumulate more conditions as we head into old age. What is the importance of that in terms of providing services for people living with HIV as they age?
I think there's several issues. The first one is, of course, actually the pipeline of new infections hasn't been turned off. So having just co-chaired with Ian Green the PrEP Access Task Group for the National HIV... Ian Green's the Chief Executive of 10 Seconds Trust, sorry. We co-chaired a group, and during that time we had the privilege of listening to somebody who has acquired HIV recently because they couldn't get PrEP. And that was our failure as a system. We failed that person. So the first point about comorbidities is we need to try and prevent them and prevent HIV in the first place. It absolutely hasn't gone away. This person, it was in the late 20s, early 30s. The second thing is that we all acquire comorbidities as we go along. And the more you acquire, the more preventable disability you have, the more you need social care. So poor primary care, I would argue, is a net driver of people into social care, for example, with diabetes, that creates frailty. And it also complicates HIV, for example, issues like your liver, your kidneys, various other things, lots of people with HIV with diabetes. Similarly, dementia, vascular dementia, HIV-related dementia and other dementia is a problem with people with HIV as people age. And so if we really want to do our job, we have to recognise that this will cost us an awful lot of money and an awful lot of avoidable disability and an awful lot of lost productivity if we don't crack it, and we have to crack it as a system. You can't have a purely NHS pathway for falls because it won't work. And I know that, having had my mother have several falls in the last 3 months. You do need a multi-agency pathway for falls. And it's the same with HIV. And actually, if you look at rural areas, so if I may be parochial for a second, in Hertfordshire, we have 37 settlements, and they'd all like their own branch of John Lewis. And some of them are big settlements like Watford, where there's a critical mass of people living with HIV that can go to local treatment. And other settlements are tiny with 200 people, where actually you need to get on 2 buses to go to the hospital in Stevenage to get treated. We need to have a model for ensuring that people can be supported and cared for wherever they live. And it's not impossible, it has been done. Norfolk's got a model, there are other places that have got a model. So I guess it goes back to sit round a table with all the interested parties, talk money, talk outcomes, don't talk governance.
Ruth,
Can I
Please,
just
yeah.
comment on that? So I think that's so important, because I think what you're saying is, rather than look at just health outcomes, one of the things we're really keen to do in our team is look at economic gain to a local area, because that sums it up really. And if we're not measuring that, we're not really looking at the full potential of everything we do. And so we have tried to link our Inclusion Health programme to the Anchors programme. We think about what we do as anchor organisations. This is the thinking that large organisations such as NHS, local authority, further education, we will have a lot of power and control to focus on local employment, etc. And that's one of the things, I think that would be a really good measure for ICSs, is to what level are they contributing to good economic gain of a local area.
I agree, and if I can do a 30-second comeback on that degree, being purely selfish, I have employees with HIV in my work life, in my life outside work as a trustee of a large hospice. We have employees, and as a volunteer for an HIV organisation, we have employees. And selfishly, I want them all to work and until they're ready to retire, because if any of them left, it'd be like losing a right arm, and they are massively crucial. And actually, a health care system that keeps them thriving is what we should be, psychologically, physically, spiritually, in every way, is what we should be aiming for. Sorry.